So I want to just acknowledge Karen Palmer from Waikato Hospital for this traffic light little weight loss parameter table, because we talked about physiological being 5 to 7%. When we're getting to 10%, we need to be asking the question, is this okay for this baby to have lost 10% of its birth weight, or is it not okay? Should I be assessing further and putting a plan in place and following up more frequently? Now, Lindsay did talk about that recent HDC case where that baby was about 4.6 kilos at birth and ended up with hypernatremia and died. Tragic, tragic for that family, tragic for the midwives involved. But I guess what I learned from that was that baby had lost 16% of its birth weight when it was first assessed. The midwife consulted with a colleague. She put a plan in place, but somewhere between her going on holiday and handing over to a colleague, the baby fell through the gaps. And there was no quick way.
She consulted with, I mean, it's 16%. She should
Yeah.
have been consulting with a pediatrician.
Yeah, so she did, you know, I don't know who it was specifically, but I think it might have been a midwife or a lactation consultant colleague.
And what's the time frame for this? Is that like how long after birth? That
This
weight loss?
10%?
Yeah.
We're talking about by about day 5, losing 10% of their body weight, and then by days 12 to 14, either regaining their birth weight or on their way to regaining their birth weight. Okay, we want to see an increase. 12 to 15%, this baby needs to feed. Even at 10%, I'd be going, this baby needs to feed. Why is it not feeding well? What else is going on? Consult. Maybe urea and electrolytes, because that baby could be developing hypernatremia. And then 15 to 20%, that baby definitely probably needs admission. And that baby in that particular case, HDC case, had lost 16% by about, I think, day 5 or day 10. So you can see, you know, real problems if we don't activate some action way back here at 10% weight loss. We need to act early. For midwives, the referral guidelines are very clear. There are 2 types in relation to growth and feeding. If there's sustained feeding difficulties in a newborn, we should consult. If there's dehydration, or greater than 10% weight loss since birth, we need to consult. And it's interesting what the consultation definition is in the referral guidelines. It says, seek an assessment, opinion, advice from another primary care provider or a secondary tertiary care provider. Okay, so maybe that midwife was okay to consult with a colleague at that stage, put a plan in place, provided it was a reasonable plan that was going to help that baby. But maybe she should have, given that it was 16%, taken much more stronger action and consulted with a secondary or tertiary specialist. And they also talk about there that the consultation can be in person, by telephone, or by other means as appropriate in the situation. So there's a lot of leeway for consultation, but we need to get a second opinion. So it could be a lactation consultant, it could be a colleague, or a colleague saying, actually, 16%, I think you should talk to a pediatrician about that baby. So we need to be aware of these guidelines because we are held to account. And if we decide, if I decide as a lactation consultant, and I have, that I will look after a baby who's 12%, put a plan in place, follow her up daily, which I do, especially with some rural ones, to see that there's no downward trend, but rather an upward trend, I bear the consequences of that decision myself. I cannot say anybody else is responsible for that except me. And I then need to make that decision where this is way beyond me and I need to consult with somebody who has greater knowledge than I do. And sometimes it is a fellow lactation consultant, but sometimes it is me going, actually, this baby's just not doing what it should be doing. Something else is going on here. So we've talked a little bit about what is abnormal, and we've also talked about that whole issue of what is hypernatremic dehydration. And it's interesting when you look at the literature around hypernatremic dehydration in breastfed babies, that while they say more than 10% weight loss is abnormal, some of these babies can lose up to 30% of their birth weight in the first 5 days, which is grossly, grossly abnormal. And guess what? Mostly it's in women with having their first baby, which was this particular case. It was a woman having her first baby, because, you know, babies' behavior is quite variable. There will be babies who drink and then they'll sleep for a long period of time, and mums will think, gosh, that's great, I can catch up on sleep. And that it won't occur to some of them that that's not, maybe not normal for that baby, that that baby needs to be feeding more often. And yet there'll be other mums who will be much more conscious of that. So we cannot assume that every mother knows the same thing and will call if she's concerned or not. These mothers also need really good follow-up support. So how is hypernatremic dehydration first identified? Well, you know, the problem is that it can start with poor feeding, lethargy, excessive weight loss. The baby may be suckling at the breast for long periods but be getting very little milk in and failing to thrive, or the output is quite poor. Falk et al. From 2008 in their research said actually hypernatremic dehydration is notoriously variable in its clinical presentation. So some babies may look great, others may look dehydrated, may look very unwell. So that's where we have to be going, let me do a thorough assessment of this baby, let me get a second opinion, let me take action before this baby is so hypernatremic that it then develops all those consequences, which are things like renal failure, jaundice, intraventricular hemorrhage, seizures, brain damage, and finally death, which none of us want to have that happen to the babies we look after. Obviously, the treatment is to get that baby to hospital quickly, to rehydrate it slowly, and to monitor the sodium levels until they're back to normal. Because if they're rehydrated too quickly, they can also be a problem for them. So prevention is actually much better than getting to this position. And I think it's quite rare now. It used to be very common, but it's quite rare. So we want to keep it rare by being good observers of our babies, good follow-up, providing good follow-up of our babies. So I've talked all about this already, just to remind you that Noel Weiss, again, in her research has said, actually, I've searched the literature. I can't find that magical, you know, the research, it says 10% is the magical number. But it is the number that we've used for years to say, you know, when your baby falls beyond that, start looking closer, put a plan in place, help to feed that baby. And she says, even if you don't think that's a good number, the 10%, use it as a red flag to make you take action. Because if you don't take action, the next time you see that baby, it could be at 16% weight loss since birth. So what are the things we can do? Obviously, check on the ABCs. The A is access to the breast. Babies need access. If the mother's wanting to sleep, they're not going to have access. If the mother's depressed, they're not going to want to give the baby access to the breast. If the mother's busy going out, ashamed to feed in public because family's there, because there are men in the place, they may not give that baby access to the breast. They'd wait until everybody's gone. So we need to talk about how they can manage that in order to give that baby access. What about the breast milk transfer? We've talked already about that whole thing of, is the swallowing truly milk swallowing? Is the suckling really effective suckling? Because I've watched mums with babies, and you can hear when the milk is coming down, you see those big drawing sucks. And then once the milk flow slows down, the baby starts just, again, suck, 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 and you're not getting that suck, swallow, breathe. And so then we end up going, are we hearing that swallowing? I don't know if you've noticed, a lot of mums turn the TV up or the radio's on, and I often go, I'm going to get really close to that baby, run against its back to hear the swallowing. They need to learn what to listen for, and they need quiet in the room to hear that, to know the transfer is taking place. And of course, they need to be comfortable, because remember, if the mother's in pain, she's tense, adrenaline pours out, oxytocin can't be released, which helps the milk to flow. So we need her to be comfortable. We need her to be relaxed in order for that milk really to flow when the baby's suckling. So what are the 3 B's that we need to assess? First of all, it's the breast, because if that baby's not gaining, does the mother have enough milk? We need to check what was the breast growth like at puberty, pre-pregnancy, during pregnancy. What's the milk production been like? Thinking about when milk normally comes in. Has she expressed and stored colostrum? Now we'll go on to this here, even though I've got a little slide later. I believe that is one of the best things we can do to mothers, is help them to learn to express and store colostrum. Colostrum comes into the breasts at 16 weeks of pregnancy. Most women are unaware of it. Some are aware from 25 weeks on, the bed's wet, they kind of think, what's happening to me? And if we teach them how to express, which is one of the 10 steps of the Baby Friendly Hospital Initiative, how to express during pregnancy and to store colostrum if they've got colostrum enough that they're able to express into a teaspoon and suck up into a syringe and freeze, they will have colostrum as the first milk for their baby if they ever separated from their baby in those first hours or days after the birth of the baby. I've used it with my clients for years now, and so many mothers have said to me, wow, you know, I'm so glad you taught me how to do that. That was the best thing I've ever done. And so if you don't do it, have a look at it, consider it for your clients. Even for those women who are diabetics, overweight, they could benefit from something like this. What are the woman's nipples like? Remember, nipples are different for every woman. Some look up, some look down, some look in, some look out. That's all normal. But each of us only sees ourselves. Most women don't know what's normal because they don't see everybody else's breast, but that's normal. But are they flat, inverted? You know, in the past we used to do all these exercises to bring the nipple out. Women talk about having scrubbed the nipples and, you know, all of those things. We don't do that anymore. And so actually we've ended up never looking at women's breasts during pregnancy, whereas actually we should be doing that. Not to make them scrub the nipples, but so that if there's a problem with flat or inverted nipples, we can start working on that early, because nipples should be treated like we treat our lips. We don't scrub our lips with a scrubbing brush or sandpaper. We put lipstick on or lip gloss to keep them soft. Same thing with the nipples. Talk about breast surgery, because they're women who've had implants or breast reductions. I've got one woman who had implants just recently between babies, producing milk greatly. Beautiful, no problem. And we are seeing that with recent surgery, there is no disruption of the ducts, so they can still breastfeed. So let's not make any assumptions. If you've had, you know, an implant, you're never going to be able to breastfeed. I've got one woman, however, who had a reduction in her teens, who with her first babies has not been able to breastfeed as in enough milk to nourish those babies, but she's put the babies to the breast. So, you know, even if they're not going to produce the amount that's needed to exclusively breastfeed, for them it's that sense of, I gave my baby even the first few drops of colostrum. So I never say to a woman, looking at your breast, you'll never be able to breastfeed, because guess what that does psychologically? Oh, I'm a failure, my body's a failure. She just needs to know there may be a few challenges, but hey, let's try it and see what happens. And then think about her medical conditions. Has she had a pituitary adenoma? This particular woman who agreed to this, you can see her breasts are really normal. Nipples great. She had a pituitary adenoma. She was on bromocriptine, which is a milk suppressant, and also suppressed that adenoma, which helped her get pregnant. But for some reason, her volumes of milk post-pregnancy were so low, her baby just could not grow on exclusive breastfeeding. So we had to introduce formula quite early. Diabetic mums, those with severe hemorrhage, Sheehan syndrome, just to be aware of those things as affecting milk supply for mums. So again, it's a whole assessment, whole picture, history. Think about the baby. Check that oral cavity. We've already talked a little bit today about the tongue, but look at the jaw, the lips, the cheeks, the palate, the nasal cavity. I don't know if you've seen some babies after birth, they have a squiff in the face. They struggle to latch properly, those babies with a skewed jaw. And so, you know, they need a bit of time. Maybe they need some osteopathic treatment. It's alternative therapies, but it does help some of those babies. Sometimes their noses may be blocked, and being obligatory nose breathers, they latch on the breast. They've got to keep coming off to take a breath if their nose is blocked. And I certainly had one baby born at home. He had the biggest lips I've ever seen. He latched beautifully, but I tell you what, those lips totally closed the nose. And I literally saw, and I really want to emphasize this, I saw the life go out of him. His whole body just went into this, I'm not getting any oxygen. So we took him off the breast, got those lips away from his nose, and he was able to breathe. And you know, the mum wasn't watching him because she was talking to everybody around, but because we were right there with her, we observed this, and we were going, you know, and we've had a baby die because of being at the breast, and mum's talking away to everybody on the phone, talking about this baby that she's just had, not observing that the airway's closed, that the baby isn't breathing effectively. So we have to take cognizance of that whole picture in terms of the face and mouth when we're teaching mums as well as observing the babies. Check those reflexes, are they intact? And most of them for a full-term baby should be there. If they're not there, why aren't they there at the time? And of course, wet and dirty nappies. And you know, wet, there could be a lot, but if they are not pooing, these babies, or they've got meconium still at day 5, day 6, they're not getting enough food. They need some action taken, so we need to take cognizance of that. Think about those cranial nerves. If they've had a ventouse, as Lindsay pointed out, wicked events, but sometimes helpful, a forceps, or even a cesarean. If you've watched them being lifted out with a cesarean, those fingers come behind the neck here and the head, there could be damage to some of those cranial nerves that actually feed the mouth, the tongue, the lips. The swallow and gag reflex may be affected, and the ability to suckle effectively. Those babies may need some help. Obviously, those with poor muscle tone as well need some help. And I had one woman who actually ended up after 17 weeks exclusively breastfeeding her Down syndrome baby, because she did all the work of pumping, but she also did a lot of the muscle work around the face to stimulate those muscles to get that baby to suck effectively. So initially that baby was getting expressed breast milk, and then by bottle, and then she put that baby to the breast, and by 17 weeks she was exclusively breastfeeding. Awesome. You know, what a committed mum. Absolutely amazing, because she did some work on the muscle tone. These are some of the things that Lindsay has already talked about today. Think about the jaundice, obviously. Think about things like galactosemia, the biliary atresia he spoke about, and I will talk a little bit about the metabolic problems down here. Sleepy baby with poor feeding. Oh my gosh, I had this really experienced mum, and this is where you again come back to, because you experienced doesn't mean you know or you're aware. She was very experienced, and she's a nurse. And she called me with her second baby. after about day 3, and she said, I can't understand why my baby's not feeding. And I thought, yeah, that's really strange because this baby's been feeding very well. So what's happening? No, she's just very sleepy, and put her on the breast and she just lies there like that and she doesn't feed. So I was out rurally and she lived rural. So I said, okay, I'm just finishing this visit. I'll come and see you. And when I took that baby's temperature, it was subnormal. And Mum, it was a freezing cold night and she was not aware that that baby was actually getting cold. And she didn't check the temperature. She didn't even think to check the temperature, and it was so subnormal that that baby was actually sleepy because it was hypothermic and sleepy and therefore couldn't feed. So we got milk into that baby, and she perked up and then would latch at the breast and could suckle well. So, you know, just those simple things, and us anticipating, experienced mum, she'll be fine. She doesn't need help. Actually, each baby is so different. And the mum, if she's tired, may forget things that would be a norm for her if she was the caregiver for someone else. We've also talked a lot about hypoglycemia today. And, you know, one of the things that Lindsay did mention was that whole thing about ketone bodies as energy for baby's brain. And they are. Those ketone bodies are great energy for baby's brain, but over short periods of time. So the hypoglycemia should not go on for extended periods. And that's why we need to selectively look at those babies who need blood sugar checks. Think about metabolic problems, and you will be aware that the National Screening Unit, National Testing Centre has really been hot on us as midwives getting the Guthrie card in within a 4-day time period, which is their goal. To the extent now that I get my letter to say, Cheryl, you did an 80% or 95% within the time frame, but one of those cards didn't come in on time, because there have been babies, A, who haven't had their neonatal metabolic test done, B, have had it done late, or C, have had it sent in so late that some of these conditions which could create some major problems are being detected too late. And the two of them that certainly have an influence, or that breastfeeding has an influence on, is phenylketonuria and galactosemia. And as you can see, they're pretty rare, but they could occur.
We've got 3 babies with PKU in Golden Bay. We're about 60 babies.
Yeah, so which is stunning. Yeah, quite stunning.
Yeah, but that's over 2 years, but still.
Yeah, but still, that's a lot, even for 2 years. Yeah, yeah, it is a lot. So phenylketonuria, remember, is an autosomal recessive condition where the baby lacks an enzyme to change phenylalanine to a usable form. And of course, if the phenylalanine builds up, it can cause central nervous system damage. These babies can still breastfeed to a certain extent, but it needs careful monitoring with some good nutritional, specialist nutrition input, because they also need a phenylalanine-free formula. So there's got to be a delicate balance there for those babies. And that's why we need to pick it up early. Keeping in mind that the neonatal metabolic test is only screening, but if there's a problem, the guys from National Testing Centre call, and they call really quickly to get onto it really quickly. Galactosemia, while it's very rare, these babies cannot be breastfed. So there is a difference between the two, in that the galactosemia, the babies can't be breastfed because they lack an enzyme that changes galactose to glucose, and they're unable to metabolize the lactose or milk sugar. So they need to go onto a special formula that's free of galactose. But of course, sometimes those babies may be carriers rather than having the classic duart galactosemia. And so what we often say while the baby's getting tested is that the mother keeps expressing breast milk just in case the baby's only a carrier, and therefore it can go back to, or at least use some breast milk over a period of time. So once we've checked the mother, we need to and we've checked the baby, we need to put both together and check obviously positioning and attachment. Suck, swallow, breathe. A baby who is sucking, 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 having one swallow after 5 to 8 sucks, and then breathing through after each one through a whole feed is not getting enough milk. So if you're able to watch that suck, swallow, breathe, where it's one suck, one swallow, one breathe, or 2 sucks, one swallow, one breathe, you know that baby's getting milk. We particularly hear it when there's a letdown. So do observe for that, and you've got to be there because sometimes the mum doesn't know. We've talked about milk transfer. We've also talked about attitude and stress levels a little bit. But remember, some mothers want to please you as the midwife or the well child nurse or the GP by breastfeeding. What do they want to do is what you need to ascertain. I don't want any woman to please me. I want them to do what's right for them and for their babies. And I want to help them achieve what they want to achieve. And so if they're feeling, I hate breastfeeding, and I have some women who say, I absolutely hate a baby at the breast, we got to look at, okay, so where else can we go with this? Are you prepared to express breast milk? Because I think expressed breast milk is better than no breast milk at all for those babies. And what about their stress levels? What's happening at home in terms of that social support, which we've talked a lot about already today? Is breastfeeding stressing them out because they're worried about the baby? Are they getting enough sleep? Are they depressed? Because remember, some of them would have had a family loss or moved away from family or friend support during the pregnancy. We need to be aware of those kind of things that could affect their oxytocin levels and letdown. And there is a breastfeeding assessment tool that can be used if you feel like you're needing something else to help you with that. So what do we need to do? Obviously, if there's not enough milk, increase the milk supply. And I just want to quickly again refer to that antenatal expression of colostrum. Now, while I spoke to you about, I do it with all my clients, there is no research to support it yet to say every mother who's pregnant should express and store colostrum. However, there is a study called the DAME study that is currently in progress, and it is an international study, but being led from Australia, which is looking at colostrum expression and storage for women with diabetes in pregnancy. And basically, these researchers are saying if we find this is helpful for diabetic women in pregnancy, we think we can extrapolate to normal healthy women that it would be helpful for them and for their babies as well. So do look out for the results of that DAME study. And then there's some research also that suggests getting mums to express early and often is important, that longer expressing is not always as helpful. So it's something like power pumping. Is everybody familiar with power pumping? Basically, it's short, sharp bursts of pumping. So mum sterilizes her pump, puts it on the bench in the kitchen, covers it with a clean tea towel. Every time she walks into the kitchen, puts on the kettle, she pumps for 5 minutes and then puts that milk in the fridge. And then she goes out again and does whatever. And then she comes back in to wash the cup of tea that she just finished. Oh, and she pumps again. So that's power pumping, short, sharp. And in fact, Dr. Jane Morton from Stanford University has shown that she can get women to increase their milk supply by pumping and hand expression at the same event. And she's done some really good research on that, and she's so generous. She said, look, if you go to my Stanford University website, you can use all of that information there for educational purposes. And this is one of the little clips from one of her videos to show, and that's her website there, newborns.stanford.edu. And what she showed through this research was if the mums, and the yellow and the black lines are for healthy full-term babies, the red one is for preterm babies. But if a mum with a healthy full-term baby pumps only, she gets that amount of milk. But if she pumps and hand expresses, she significantly increases the volume of milk she's able to get for her baby by pump and hand expressing. And this one with the preterm, she said within 3 days of birthing a preterm baby, that mum should start pumping and then get into the pumping and hand expressing, and she is able to increase her milk supply significantly. So do look at Jane's work. She's got some really good information on her website. Obviously, managing a large supply is another big thing. You know, when Philip was talking about those reflux babies, and crying babies, colicky babies with a large milk supply, mums often think, oh, my baby's crying, they must be hungry. We need to teach them there's more to crying than hunger. So every time they put that baby to the breast, they're going to increase the supply, because the more that's moved, the more is produced. And so what else can they do? And I've had women who just feeding, huge supply. These kids are drowning in the milk. They're breast averse because of it. They throwing up and literally power chugging, but they don't have pyloric stenosis, but they're gulping huge volumes of air, and they bring up, you know, the winds, and they power chuck across the room. So those mums need a lot of help to understand what are other reasons for crying. That's not just because of being hungry. How else can I comfort my baby? And then also, sorry, I'm going over time, I'm trying to hurry. The positional feeding as well, that upright feeding is really important for them. And those mums may need to do something like block feeding, where they are feeding from one breast for a 6-hour period of time, resting the other breast, only expressing for comfort, just to settle the supply on the one side. So there are a few strategies there. And then don't forget about that neonatal test. Document that plan, evaluate it. That consultation is important, and referral, as well as educating the parents. And this is also from Jane Morton's website, which she's really happy for you to use. You could use this to teach mums about, what does this mean, how do I know that my baby's well fed? If I can tick yes for all of these, including on the next page, my baby's good. But if I answer no to any of these questions, there may be some problems with the feeding, and I need to call for help. My midwife, this is US obviously, and they mostly see pediatricians for help, a lactation consultant, my GP, my well child provider, Plunkett line, health line, okay, lots of places to go. So, you know, that's part of us helping mums. Okay, so I think we've covered everything, and I think just to end off with, again, listen to the mother's concerns, and that's been a theme today as well. Listen to the mother's concerns and do good assessments, including a full history.